As you know, in any chronic disease, nobody wants to take medicines daily. It's not that you don't want to take it, it affects your lifestyle. You forget it, you're doing other things, you're going on trips, so it's hard by itself to even take a medication daily. And then it's even harder if I tell you, hey, step up your medication, and not even when you're sick. I want you to step up actually when you start getting a cold. So it's not even when you're actually wheezing, right? So it's sometimes hard to remember I need to do something. That is a trick, and we don't like to complicate the lives of our asthma patients. But if you balance it against, do you want them to end up on oral steroids and in the hospital? No, I don't want that. Why do I not want that? If they keep doing oral steroids, it leads to long-term complications. It's been shown over and over again, is the additive or cumulative doses that cause a problem. I don't want my little kids to be citizens later with broken bones. So that's something I really don't want it to happen. Europe and Canada also has a single inhaler where they have inhaled steroids and short-acting beta agonists in one inhaler, which means every time you use albuterol, you use your ICS. We need strategies like that here. I don't know if the companies are coming up with it, but that is something we would really like, and that would make life easier, right? What we do to combat the fact that it's complicated is a lot of education. So we give written action plans with directions on it. If they bring the inhalers, we label it. We educate the patients. We also have pictorial asthma plans when needed. It is education, and it's not like one strategy fits all. You have to change between strategies, and therefore the follow-up with the doctor and going over the plan. Did it work? If not, why not? Did you not start it early? Did the medicine not work? Was this too complicated for you? We do try to simplify it, but sometimes the exacerbation, the problems with it can be so bad that you really want to not have it. And maybe just taking an additional inhaler, even though it's hard, may not be that big a deal compared to having to spend 24 hours in the emergency room. Right now, the practice parameter looked at the evidence just because, believe it or not, a lot of clinicians are actually using these strategies. And one, it validates their approaches because we want to help our patients. The goal is, in the end, no matter what, we want to help our patients lead good lives where the asthma is not a problem with how their life is going on, and they're not spending a lot of the time in the emergency room or having adverse effects of medication. So that is the ultimate goal. How do we reach that goal, if that's what you're asking, is first to come up with evidence that, look, there was a gap in the guidelines. There are newer studies. We need to look at those studies. Maybe the NHLBI needs to look at those studies now and change the guidelines, update the guidelines. And then we need to see if having data that's evidence-based may want the FDA to look at it again and say, maybe we need to update our thinking. There are newer studies. Maybe we need to relook at this again. And maybe it will stimulate pharmaceutical companies to come up with a single inhaler that will solve. And some of the companies are actually know that and have that at mind. It's a long process, as you know, before a drug reaches a market. But asthma or any disease varies. So children are not little adults necessarily, right? Even the guidelines recognize that. When they talked about daily asthma control, they classified it as 0 to 4 years, 5 to 11, and more than 12. We wanted to use the same approach, but we couldn't because we didn't have enough studies that used that approach. So in a loose manner, these guidelines are applicable to older children and adults. In the children less than 5 years, to be honest, nothing seems to work when they get their viral wheezing. Now, the children who are more prone to asthma, true asthma later, as evidenced by something called a positive modified asthma predictive index, meaning they have certain criteria that predispose them, family history of asthma, or they have allergies themselves, or their skin test positive. Like the more allergic kids, in them this strategy seems to help. But in the regular kids who wheeze because of RSV or something else, it doesn't seem to help. We don't have age stratified guidelines, but hopefully with more studies that will happen.